My name is Landewe. I'm a rheumatologist working in the Netherlands, both in Amsterdam, where I do my research, and in the south of the country, which is in a city called Heerlen, where I see patients 1 day a week. And the patients that I see is the entire spectrum of rheumatology. What I've done here is lecturing about spondyloarthritis. Spondyloarthritis is most familiar to you as ankylosing spondylitis, but nowadays we talk about spondyloarthritis in a broader spectrum. It's actually the disease that is characterized by chronic inflammatory back pain, syndesmophyte formation, and association with the gene HLA-B27, and you're very familiar with that, I'm very certain. So the lecture had as a main topic the diagnosis of spondyloarthritis, in particular how you rely as a rheumatologist on radiographs, pelvic radiographs and pelvic MRI. And obviously that is a hallmark in the diagnosis of axial SPA. But what many people do not know too well is that you can make serious mistakes in the interpretation of X-rays and MRI. And although we know that already for a very long time, I must say during the last couple of years we have learned far more about how unreliable looking at pelvic X-rays in patients with a suspicion of spondyloarthritis really is. So we have made a lot of progress, and the main conclusion of those years of research and also of my lecture is that you should not solely rely on the results of imaging, on the results of pelvic X-rays or MRI, because there is so much more that is important in making a diagnosis of spondyloarthritis. There is the clinical symptoms of the patient. As I said already, there is inflammatory back pain, but also the so-called SPA features. Patients with a family history that is positive for spondyloarthritis are at a far higher risk of developing spondyloarthritis. Patients can have arthritis, so not only back pain, but also arthritis, or a history of acute anterior HLA-B27 related uveitis, as you know. And other diseases like Crohn's disease, psoriasis, etc. also belong to the entire spectrum of spondyloarthritis. And although we have learned in the past that rheumatologists pretty much rely on the outcome of imaging tests, it also turns out that this is not the best way to make a diagnosis of spondyloarthritis, axial spondyloarthritis, in a patient presenting with inflammatory back pain. What you should do actually is collect as many symptoms as possible and as many information as possible, and also relate that to the outcome, to the result of the imaging, the X-ray or the MRI, or maybe the X-ray and the MRI. And that it sharply increases the likelihood that you make a correct diagnosis of axial spondyloarthritis. It sort of avoids too many misclassifications, misdiagnoses. And that is a relevant kind of thing in the era in which we tend to treat patients with axial spondyloarthritis with very expensive treatments that not everyone can afford, that not every country can afford. And we should be very careful with prescribing these drugs to patients that actually cannot expect any benefit from it.